sort of do a Price is Right kind of thing and come on down and mingle with you. We'll see how he does. He's a really excitable young lad, and as I said, he's very special in many, many, many ways. Among one of the ways he's very, very, very special is he has a diagnosis of severe combined immunodeficiency, or perhaps had the diagnosis of severe combined immunodeficiency. I'm going to give you 7 slides of SCID, and then we're going to waste any time. We're going to get right to meeting Jackson. We'll see how he does. We have his mom here today. We have his grandma. He seems to like the iPad, so I think that'll amuse him while we're talking about medicine. And there's a very important principle, I think it's an important principle that I want to relay to you guys that SCID represents. And many of the treatments and the types of therapies we've proposed in regenerative medicine, in my bias, in my view, actually derive from the successes of hematopoietic stem cell transplantation. There are many principles that transplanting diseases like SCID represent, and let me list just some of them. So the idea that you can transplant a long-term repopulating stem cell comes from the early experiments in animals and in the clinical trials with bone marrow transplantation. The goal is a lifelong treatment that is a cure. The idea that you would do conditioning, this is also a concept that came from bone marrow transplantation. So in conditioning, what you do is you try to get rid of the innate tissue that is not working, and in this case it would be defective bone marrow, a defective immune system, and you replace it. And the concept of conditioning in bone marrow transplantation is through the use of chemotherapy. So you myeloablate, and as I told you yesterday, you can partially myeloablate with reduced intensity, but then you replace. So that's another important concept that may relate to other stem cell transplantations. A second concept is getting the new tissues and the new stem cells to synchronize, to become part of that person. And in the case of bone marrow transplantation, I showed you guys yesterday the concept of using immune suppressive drugs to prevent graft versus host disease or engraftment loss. It's possible that with future regenerative medical applications, whether we're using pluripotent stem cells or otherwise, we may have to steal some of these concepts and apply them, such as conditioning, allowing the new tissues and the new stem cells to become part of the person, and possibly using supportive medical therapy to get that to work. Now, the paradigmatic disease that started bone marrow transplantation back in, all the way back in 1968 was SCID. This was the original disease for which people proposed you have a replacement of a defective blood system with one that is not defective. And SCID was a perfect application because SCID is a fatal disease in the early months of life if not corrected. And so patients, babies who are born with SCID are often diagnosed very early in life with severe infections, and if you don't do something, they generally don't do well. And the first bone marrow transplant, as I said, for SCID was for X-linked SCID, and there are different kinds of SCID. There's X-linked, which is due to the gamma C chain receptor, which Jackson has, and there's also an ADA SCID. There's actually a whole family of them. There's over 20 or 25 different types of SCID. And when people started to first do bone marrow transplants, the treatments were often very caustic, and sometimes you wouldn't even survive the bone marrow transplant. Since then, bone marrow transplantation as a field has gone through a progression of improvements. It's become safer and safer and safer. And Jackson has inherited the success of over 50 years of improvements in bone marrow transplantation where we can do them safely and effectively. And it's still one of 2 potentially curative methods besides gene therapy. It's the paradigmatic disease, the primary immune deficiencies, and from the concept of transplanting SCID is also the concept of transplanting other diseases, such as autoimmunity, such as rheumatoid arthritis, perhaps such as Crohn's, where you have defects in the immune system, perhaps diabetes type 1, where you basically have some flavor, some form of defective immunity that you can replace. And SCID is the paradigmatic example to follow. but the preliminary strategies that were used often led to incomplete reconstitution of the immune system. And over time, we've learned how to give the chemotherapy just right to condition them. Over time, we've learned how to give supportive therapies, antivirals, antibiotics to prevent the complications. And over time, we found ways to prevent graft versus host disease and optimize optimal engraftment. And as I mentioned yesterday with the boys that you guys met yesterday, one of the latest innovations is that we don't need a perfect match. We can do haploidentical half-match transplants with ease and with success. Jackson had a matched unrelated donor, and so we could have potentially treated him. But Jackson is an interesting case because some of the methods that we have innovated here at Johns Hopkins for doing haploidentical bone marrow transplants are not yet safely done in babies. And Jackson was diagnosed as a baby, and so we had to use a more traditional bone marrow transplant regimen. It was still reduced intensity, and he sort of got an old school type transplant where he got a matched unrelated donor, which is what we would have done 10 years ago. So all the stars aligned just right. Now you don't need to know the details of SCID, but I present this slide just so that you have a flavor that it's a heterogeneous disease. You can have problems with B cells and T cells and NK cells in various combinations, all which result collectively in a defect in humoral and cellular immunity. And the key to success is getting a good donor. The key to success is some SCIDs have a better prognosis after transplantation than others. The key to success is managing the post-transplant complications and the pre-transplant complications. The healthier the baby is before we transplant, with the fewest infections, the better they tend to do. What does that mean? That means that you must diagnose it as quickly as you can, and genetic screening at the neonatal stage becomes critical. And Jackson had the advantage of that. The age during the transplant also plays a role. Younger is better, older is not as good. The use of prophylactic antibiotics, the use of sterile conditions, and it's come to the point where the cure of SCID has become sort of an algorithm, although it's not reached its final destination. And this is an example of an algorithm that the European Society of Bone Marrow Transplantation uses. You don't need to know this. You just need to know that there is an algorithm that has to do with the age, whether they have a donor or not, what kind of donor do they have, is it a matched unrelated donor, is it a matched sibling donor, or is it a mismatched donor? And there's a hierarchy of ways that people have devised to do these kinds of transplants safely. And the other key to success, and again, I use SCID as a paradigm to possibly other regenerative medicines, such as taking pluripotent stem cells, where you would need to do conditioning and use some kind of engraftment strategy. The other key to success is once you transplant the patient, you're not done. The post-transplant follow-up is just as important, and we'll learn about that with what Mom has been doing with Jackson, but you need to make sure that it worked well, that you truly did get immune reconstitution. Are the B cells working just the way that you would expect? Are they making the proper antibodies? Did you get proper T cell reconstitution? Do they respond to vaccines? Do they get sick anymore? These are sort of general pediatrics, right? This is like the realm of your general pediatrician that would do an annual follow-up. There are also endocrine and fertility issues post-transplantation, and there's also the concept of genetic counseling if the family wants to consider having more children in the future, and possible neonatal testing. So this is a picture. I'm going to ask Mom and Jackson to come on down. This is a picture of Jackson. Jackson, Erin, and Grandma. Grandma, do you want to hang out with us? You're welcome to. We'll see how Jackson does. So far,
Better grab my notes.
Yeah, if you need them.
I don't want to forget anything.
I'm sure you won't. Why don't we start by, Erin, can you tell us what's going on here?
So that was actually during chemotherapy. I can't remember which day. I know he had 10 days of chemotherapy. And I would say this is one of the scariest days. If you actually see the actual picture, he is a lot more brighter like that blanket. So it just, and then if you can see his right foot, he had an IV placed in his foot, and he had a lot of yeast issues. So it actually created yeast on the bottom of his foot, and the tape and everything. His skin could not handle anything. He was peeling so bad. He looked like at some points he had cauliflower ear because he would just welt up really bad of yeast. He just could not tolerate anything.
How old is he here?
He had just turned 4 months old.
Wow. Okay, and you're gonna have to excuse me because I don't actually remember all the details, so you're gonna have to help me out. How old was he when he was first diagnosed with severe combined immune deficiency?
Okay, so this is a great story for you. We actually were driving to the pediatrician's office. It was the second day of a checkup for him. And I kept looking at him in the back seat, and I kept saying, something's wrong. I just felt like mother's instinct, something was wrong. And he already gave us problems with birthing and everything, because come to find out he had GERD on top of everything.
He had GERD, G-R-U-D? What did you say he had?
GERD.
GERD.
So he actually turned blue a couple of times after he'd been born in the hospital. So it was another issue we had. But we were on the way to the pediatrician's office, and once we arrived, we were sitting in there, and Dr. Hinkle, his pediatrician, had gotten a phone call, and my mom was with me. And I said, wow, that sounds serious. I'm glad it's not for us. Well, they came back in, and they said that call was for Jackson. And they handed me a paper, and she started talking about SCID, and I felt like I had heard about it before. So I already had this pit in my stomach. And I read...
So this was a newborn screen test
Yes.
result? Okay.
His heel stick test, they actually, I believe in 2016, started testing for SCID, thankfully, because he has a sister who's 3. So if they would have been switched, we would have had a major problem. But she came in and handed me the paper, and of course I read the diagnosis, and immediately, what are you going to do? You're going to look at the treatment. And I saw bone marrow transplant. And seeing one too many Hollywood movies, I just lost it.
There was a famous movie, The Boy in the Plastic Bubble. Did you ever see that?
I've heard about the John Travolta one back in the
I think
day.
that's the one, yeah.
But then they have the other goofy one. I don't know if you guys have heard of that, The Boy in the Bubble, that's the comedy, which I saw in high school back in the day and did not even remember this. Now it's not a laugh anymore, but I do remember when she came in, and she knows me very well, and she just explained what SCID was, and she said, don't be too concerned. The newborn screening is made to be very sensitive. So it could just throw up a flag, and we're going to retest him. That day was horrible. They poked him like 5 times as this little baby who, I would say he was 5 days old at this point. And 2 days later, we were at Hopkins. So we were extremely lucky. His immunology doctor, Dr. Letterman, and Dr. Dancer and Dr. Younger played a very big role as well in his life in getting him in there as soon as possible.
So I'm curious, how is he growing?
He's definitely not failing to thrive anymore.
No, but how was he doing at the time? Yeah, let him walk around. I think he wants to be friendly.
Yes, he does.
He's a very friendly guy.
He is. He loves everybody. He never, ever will have stranger danger. He has met one too many people. Hi.
How was he, were you breastfeeding him, giving him formula milk? What were you doing?
So originally, I was trying to breastfeed him, and he was actually spitting up the breast milk. And then I found out that I carry a virus in my breast milk.
CMV?
Yes, I carry CMV. And I had to immediately stop because I heard that can kill him.
And so you had to stop the breastfeeding?
Yes. Actually, well, I didn't know right away, so I continued to pump and freeze everything for him, hoping, because we just had this bond from the beginning. So I was hoping that I was going to be able to breastfeed him, but we couldn't. So we switched to formula, and it was the AR formula for acid reflux after the newborn formula, and we eventually ended up on Alimentum with him and an NG tube.
But where was he on his growth curve?
Was he?
He was not normal. So one of the things that happened in SCID is you get a failure to thrive. So I don't remember exactly it, but I think he was down in like the 5th percentile.
He was very low. I know he reminded me, I hate to compare him to an animal, but one of the Shar-Pei dogs where the skin is literally hanging off of his body.
Oh boy.
He was under his birth weight when we admitted him in the ER.
So he was not looking all that hot, and when you received the news, you probably started to Google and stuff.
Yes, Google is not your best friend. I'll tell you what though, reading from what I remember about certain types of SCID, I was actually thankful that he had X-linked. I don't know why, I just felt like that was easier to fix in my head, and it seemed a lot more common from what I've read. And I know when we tested him, Dr. Letterman, I believe it was JAK3 or... It's the
GABA-C receptor chain, but it affects the JAK-STAT pathway.
I think they looked at that one and the X-linked, and of course it came back X-linked.
And as I mentioned in my slideshow, one of the biggest things that have increased the prognosis of SCID is really early detection, and then the neonatal screening is critical. And it's been one of the greatest innovations for fixing SCID with bone marrow transplant. Having a good match is the other thing. And as I said, some of the chemotherapy medicines that we use, like for example, we met some other bone marrow transplant patients that were a little older yesterday. And there are certain chemotherapy agents that we use in those patients that they can tolerate. Their liver can metabolize it. But we're limited in babies. We're limited in the therapies that we can give because their livers are not quite yet mature. So there isn't as much innovation with babies, but we were able to figure him out. And tell us about do you remember what we proposed for you? It's probably a haze, but
the first time we
had a discussion. What did we say?
Which time? When we were deciding
about what we proposed, what kind of transplant?
We were looking at his bone marrow transplant. I think we even looked at gene therapy, like off in the distance if we had to.
Right.
We did. My daughter Haley and his dad and I had all gotten tested, swabbed, came back 50-50. We weren't a match. And so then we looked for the unrelated donor, and of course I knew Dr. Zambidis after Dr. Letterman, and he, from day one, Dr. Letterman seemed so confident that he was going to find him a match. That it took a little bit of relief off our shoulders.
That's good to know. That's more confident than I was.
Oh, he was, well, that's good to know. No, but he just seemed so confident. And I remember one time Dr. Younger, if you ever meet her, she was holding him and she said, "I'm in love with you already."
Aww.
And that told me right there she was going to do everything that she could to help him. And that's one thing you have to think about with parents. Like, we put all our trust in you and we just, if we trust you, we know you're going to do everything you can to fix our child, and we need to feel that, because that's all we have is that hope.
Appreciate that. That's a very kind thing to say. So tell us about the transplant. So how long were you in the hospital, and how did it go?
So Jackson was having skin issues, of course.
I can see that.
Well, this looks a lot better. This is loaded up on Aquaphor. His nurse was very good about just greasing him up, which helped so much. I know it looks like a lot, but it really fixed him. His ears were actually bleeding and swollen before we came in the hospital. Down in his diaper area, he had completely broken out. On the back of his legs in the creases, you could see a rash there as well. And Megan, his case manager, I actually sent her pictures, and she talked to Dr. Zambidis, and they said, let's get him in here. It was October, I believe, 5th or 6th, I believe the 5th. We got him in, we made him better before we made him worse with his skin. And he looks so much better, but like I was saying, you can even see the creases in his legs and right around on his foot. And he just, that's one thing in a SCID baby, you will always see the skin look terrible.
So we have, just for the students, we have a lot of challenges in transplant babies. We're dealing with immature organs. We're dealing with the potential to get infections fast. And we're dealing with the idea that chemotherapy may cause more toxicity than it would in an older child or in an adult. For those that are keeping score, remember I mentioned a medicine called Campath, alatuzumab, anti-CD52, which is an innovation that allows us to use less chemotherapy by immunoablating. It depletes B cells, T cells, macrophage, and a lot of different types of cells. And he got some of that. He got it 7 days before his transplant. You may also, if you're keeping score, remember a drug called fludarabine, which is a DNA synthesis inhibitor, which is kind of low impact and also allows reduced condition, and he got that. And then he got a medicine called busulfan, which is metabolized in babies better than melphalan, which is the drug that our other patients got. And so he tolerated that pretty well. But tell us about how the transplant went, when he got counts low and everything.
The chemotherapy was the toughest part. Once we got through that, I believe he had a day, was it a day before we ended up doing the bone marrow transplant?
So-called day of rest is what we call it.
Yeah, but I know that I don't remember why we used vancomycin in his central line, but he did develop the red man syndrome. So we had to pre-treat with Benadryl before we did that and run it slowly. I know that he was also on like a pre-med for his central line for fungal.
Probably for fungal, yeah. We often give them antifungal prophylaxis with a medicine called mycofungin, which is a good broad-spectrum antifungal. I mean, we have a situation, if you really think about it, where we have a patient that has a very weakened immune system, and in order to fix him, we actually have to give him chemotherapies that will actually make him even weaker, at least temporarily, until he gets a new immune system. So it's a precarious, transient period before things start working. So do you remember how long it took for him to get his new counts?
I know he started engrafting early. It was day 7 and a day 8.
Yeah, that's really early.
And I mean, luckily,
typically it takes 2 to 3 weeks.
Right, in our head, we were sitting there thinking 2 weeks. Well, I remember during that week, of course, he made me very upset during that week, but he was sitting there and we were running all kinds of tests. I remember that we were trying to figure out why he had a fever, what was going on with him. I don't know everything they were looking for. I probably don't want to know. But I do know at one point that his vitals were a concern and he had a code blue. Did you know that? He almost had 2 of them. But he had a code. Did he become
apneic?
No, they warned me they were going to hit the button. The nurses warned me. And no matter how much you warn a parent, it doesn't matter. When we see you pull down the oxygen mask, I lost it.
It was very scary.
Yes, it was extremely scary. Plus you have about 50 people standing at your room and in the halls, and there's backpacks and things are coming off the wall. But he ended up being fine. He didn't go to PICU or anything like that. And I know he engrafted day 7 into day 8, which I guess that's why he was running the fever the whole week. He was beginning to engraft, which was nice because it wasn't a 2-3 week waiting game. I know after that he ended up, the second code blue he almost had. Of course, he has to do things where he has a new nurse during that day. And everything new with him is just that poor nurse who doesn't know him. So he ended up...
It's very complicated.
Yes, and he ended up somehow getting croup. And we actually would have been able to leave the hospital early until that had happened. We had a humidifier basically right in his face. And when he had the first sign, the nurse was standing on his side of the bed with all the cords hooked up to his central line. And all of a sudden he began coughing on me and I saw his mouth turn blue. And she saw it too, and I grabbed him and I ripped him up and I just started beating on his back because I didn't know what was going on. And luckily that broke whatever it was up. And she told me, I go, did you see that? And she goes, oh yeah. She goes, I was about to hit code blue on him if he did not stop. So.
Wow. I have a lot of questions, but I think I want to open it up to the medical students earlier than I did yesterday. Do you guys have some burning questions at this stage? A lot of scary things were going on. Back in the back. You have a microphone back there, right?
Broken mic.
All right, scream.
I might be able to hear you.
Hi, thanks for coming in to talk to us.
You're welcome.
So I think you said the newborn screening started to check for SCID in like 2016, is that right?
I believe it was April of 2016, which I just recently read on Facebook. I'm part of a SCID group, which you don't want to be until after bone marrow transplant. But I just read, and I don't know how true it is, I believe it's now in all 50 states. And I don't know if it's going to be a permanent or some states may be on a trial basis.
And yesterday I had a patient with a similar immune deficiency disease that's at on newborn.
I can't hear you, I'm sorry.
Oh.
Can you hear me now? Sorry.
Yes, go ahead.
Yesterday we had a patient with another type of immunodeficiency genetic disorder, and that is not on a newborn screening. And I was wondering if you guys can comment on, like, what does it take to get something on a newborn screening?
I have no idea, but if you go on Facebook, look up, I believe it's SCID Angels, that's the group I'm part of. There is a lady named Heather on there who I believe has been pushing for all 50 states to have the newborn screening for SCID. She may know more information. She's the admin for the site.
It's a great question, and it boils down to allocation of resources. These are very rare diseases, and as I mentioned, there's also a lot of heterogeneity in the SCID diagnosis. So SCID is excellent SCID and ADA SCID are common enough of the rare disorders that they're so potently fatal that there's a justification to put it on a newborn screen. But ideally, it would be great if you could go to the lab and invent some broad newborn screen that is inexpensive and comprehensive. But I think until that happens, probably only selected diseases will make the list.
I think I read the other day that part of the newborn screening, do you know if they're testing like 50 different diseases? I think I read that
About right.
in the
You
brochure.
have some of the common ones like sickle cell anemia and SCID is in there.
Just little
Phenylketonuria and a lot of the general pediatric disorders. That's a great question. Other questions? In the middle there.
I was wondering how Jackson's developmental milestones have progressed since having the bone marrow transplant.
Excellent question. She stole my question.
Well, he's very good right now. We live, am I allowed to say what county?
It's up to you.
Okay, we live in Cecil County, and we had infants and toddlers come to our house quite a bit because he was behind. I think when they came, I want to say he was almost a year old or so, and he just was probably like 6 months behind. But he didn't want to be behind because he was very determined to roll and chase his sister around the house. He wanted to do, and I really think she had a big part of pushing him. He just wanted to be a big kid. And I mean, we haven't been seeing them now for a couple months. The only thing going on with him is we have a feeding evaluation at Kennedy Krieger in January. Jackson actually has a short tongue, so some of the food stays in the front of his mouth, and I'm gonna have them check that out. He's now having a thyroid problem, and he's on medication for that, which I can't even tell you what that's called. But it's just a small dose. They believe he might be on it till he's 3, and then we're gonna take him off of it and see what's going to happen at that point.
Is it called levothyroxine?
Yes, thank you. And they did say, Dr. McGorry and his fellow explained to me that his brain is overacting to communicate with this, is it TSH4?
Yeah.
They probably will understand a lot more
TSH,
than
those
me.
are the thyroid axis
Right.
hormones, yes.
So I've noticed he's a little clumsy. I don't know if he's tired from his brain just overworking. And of course, one of my concerns there was when he goes to school, is he going to be tired because he's just his brain is in overdrive. So we're hoping to fix that and take him off meds by age 3. And he's come off a lot of medications.
And Erin brings up a point that I think is instructive to the students from a medical perspective. So the severe combined immune deficiencies generally affect primarily the immune system, but these are germline mutations, and there are other cells in the body that an ADA deficiency or a gamma C chain deficiency might affect, such as the brain, such as the endocrine system. So you can correct the hematopoietic system with a bone marrow transplant, but some of these patients still require long-term, lifelong care for some potential other aspects of the genetic problem that they're born with. Most of them do well, and they're very healthy, and truly the main defect is in the immune system, but it's a lifelong struggle to take care of Jackson. He's thriving so well, and he's going to do well. It's still a challenge.
Oh yeah, definitely. I mean, I still worry about GVHD with him. From what I was told, it can go on a few years, but I have been very, very careful when he goes outside. He's constantly wearing sunblock because from what I've heard, the sun can promote GVHD.
Right.
I really don't think he's going to get it. I'm staying positive because I think I have followed everything that these doctors have told me to do for him.
So how far out is he now? You said he's 18 months and he got
Yes.
transplanted at 4
October.
months of age, so he's over the GVHD, and there's 2 types. There's acute and then there's chronic. And acute graft-versus-host disease generally occurs within the first 100 days. The chronic graft-versus-host disease, as you say, can appear later. And its ultimate effects may occur even like 5 to 10 years later. Many of our patients do extremely well and don't have a problem with that. We're still on a struggle and a challenge. And what kinds of things did we do when we asked you to come to our clinic? What kinds of questions did we ask you?
In the beginning, you mean? Like when we first got out of the hospital?
We were very obsessed with the skin, weren't we?
The skin, yeah, we were always doing like nystatin and aquaphor constantly on him. After his bone marrow transplant, I did notice a very big difference. He still did the nystatin, and I rarely ended up doing the aquaphor within a month after that. And every now and then I just put a little bit on him, but really his skin is so soft. He's so normal.
How about diarrhea? Did he have problems with diarrhea? Did we ask about that? Why did we do that?
I know in the beginning we were testing for doing his stool samples. I don't really know I don't remember what you were looking for, but I know.
We were looking for gut GVHD, intestinal.
Okay.
And GVHD can occur in the skin, in the mucosa, in the liver, and in the gut, in the intestines. So we were constantly looking for that because the key to stopping it is to detect it early. We can stop it. We do a very good job of stopping it, but prevention is the key to cure there. So, and he was on a lot of medicines, right?
Oh yeah.
Do you remember some of them and why you had to take
The one I did not care for, but I knew he had to be on it, was Cellcept because I had to wake up around the clock in the middle of the night. There were a couple times I did not get up. I was one time 5 hours late, but there's always an on-call doctor. And I know the quickest way to fix that was they said give him his medicine and just start backtracking him towards the normal time. So that's what, I only had to do that twice, so I was pretty on top of that. And then I believe he couldn't eat or drink, well really drink because he was so young, like a half hour.
This was during the first 35 days after the transplant, right? Approximately.
I think so.
Yeah.
It just seemed like forever.
Did it make him nauseous, by the way?
I don't believe Cellcept made him
Because
nauseous.
it makes some patients, they don't tolerate it too much.
Jackson's actually very good with medicine. There was only one medicine he gave me a big problem on, and that was when he developed C. diff. And that was when we had his central line removed because around the site he had an infection. And we gave him some medicine as a preventative. It was a strong antibiotic. I can't remember what it was called. I believe it started with an A. And then we ended up, of course he had C. diff. I had another toddler at home, and I know it was highly contagious. And he was having accidents constantly. He had very bad diarrhea. It was getting all over me. Of course, I was more worried about my daughter getting it. I wouldn't allow her anywhere where I changed his diaper. I was constantly doing laundry, just cleaning. I was used to cleaning anyway with him because every day you have to sanitize the house multiple times. We had a pet-friendly home, and we were told we couldn't keep the pets because he was not crawling at the time. Dr. Letterman explained to me that we really had a controlled environment with him because he was so young. And I mean, they even would let us, which I forgot to bring up, take him to the park that summer, but just keep him in a corner, keep him away from people. You just didn't want to take him where they were digging in the dirt and spores were in the air. You just had to be very cautious. You really had to overthink everything. And I still do. It's in my head. If I hear somebody coughing, we move. I don't want anybody coughing near him. I know his immune system is very, very good at this point.
Questions? Other questions from the back? Over there on the left.
Thank you so much for sharing your story with
You're
us.
welcome.
I was wondering if your experience with SCID so far has affected any plans for any future children?
I will never have another child. I have two. I'm happy with two. And I think if I would have had Jackson first, my daughter may not have been born. Because I look at it, I know now that they can, if they would have known I was a carrier, I am a carrier for his disease. And if we would have known, I believe that, so immunology explained to me that they can actually take your eggs out and fertilize them.
It's called PGD, pre-implantation genetic diagnosis.
It's very expensive from what I hear, but they can do that and test them for SCID, and the ones that are SCID, that show up for SCID, they get rid of, and then the ones that aren't, that you can hopefully take and be able to have a baby. But I would never have another child just because I would never want to see this happen again. I mean, the nurse, actually his nurse asked me, and she goes, well, why not? We can cure it. And I said, I could never put somebody through this. It was so hard watching your child and just the not knowing of if he was going to come out of it.
Other questions? When did you notice a difference in Jackson after the transplant? Did you sort of start to see things getting better? And when was that? At what point? Because clearly this is not good.
Right. Well,
But at some point you started to get better.
Oh, yeah. It wasn't long after transplant that the first thing you notice is his skin. The skin stopped peeling. He wasn't bleeding. There wasn't any more yeast on him. And that was the biggest difference, but of course he had croup at the time, so I was so concerned and paying more attention to that, and me being the nervous wreck mama flushing his line daily. But I really don't even think it was a month later. I believe it was less than a month, because like I said, the Aquaphor worked so well that I would say once we were out of the hospital, I believe it was around November 11th, and he had transplant on October 20th. And we could have went home earlier if we didn't have croup. But I would say maybe even a week later. I mean, we took him to the Miracle on 34th Street a couple of weeks after we were out. We were allowed to do that. We just went on a night where we knew it wouldn't be as busy and had him covered. And he was outside.
Mask on, maybe?
No.
At some point, I suspect his appetite started to improve. Is that true?
So he gave me, his appetite improved once we had him on Zantac, and the NG tube really played a role in it. We had to get him on Zantac, we had to change the formula over, and this was prior to transplant. I would say he was born in June, And I would say by August, we were in the hospital doing this, and I had to learn before I left how to do the NG tube. Because I wasn't home long before he pulled it out or sneezed it out.
Well, his appetite must have improved, because I was
yeah.
following his growth curve. And his growth curve was going like this, and then all of a sudden it went like that.
Well, we cheated. I was putting rice cereal in his formula.
That's not cheating.
But
He definitely, something changed in him after the transplant. He was going down into the gutter.
oh yeah, after transplant, he definitely picked up. He was drinking a lot more. By December, we tried solid foods, and I did not know that chemotherapy could throw your taste off.
Yep.
And I found that out in February because he was giving me a really hard time with eating. And I was able to fill him up on Alimentum. I was just feeding him every few hours around the clock. And like I said, as a parent, this is very tiring. And then
What's eating out?
meds.
What were the typical things an 18-month-old under
He
your
loves,
guidance?
he loves grilled cheese.
Okay.
Anything with cheese, so he's definitely my kid. He loves everything. If you have it and you're sitting there snacking, he wants it. That's why I don't know if some of you noticed I had a water bottle and I was trying to hide and drink it because he'll want that. He just wants everything you have. And he is not picky. At home, he'll eat a chocolate chip pancake. He'll eat his yogurt. He likes cottage cheese. He's tried salmon. He eats everything.
Any questions in the back?
I was just wondering if you could fill in a little bit more of your story between when the screening results came back and how you got to the hospital. So it's 3-4 months.
So we found out that the newborn screening had come up for SCID when he was 5 days old. And by day 7, we were at immunology at Hopkins. They just ran blood tests, of course, and it was more of a waiting game because and then eventually we saw Dr. Zambidis, and we really only, besides for testing, we saw you only one time. But the case manager and him, I know that they had looked at donors for him because we had found out at that point we weren't a match. And there were a few they were looking at. And I know the one that they picked, when we were signing the consent forms, he said to me that, I remember when we went over the chemo Jackson was going to get, and I remember him saying Campath was the nasty one. I'll never forget that. And
Actually, it's not. Did I really say that?
yes, you did. And look, that's what that did to him. I swear that was Campath. But
Maybe it became the nasty one.
it did. But
I would say busulfan is worse. But
really?
Yeah.
Well, you had me worried about the other. But so we ended up, when we were going over there, he did tell me that the donor was a young person, and he said really...
An anonymous person, by the way.
Right.
It's an anonymous person.
Right.
You probably never get to meet that person. What would you say
Oh,
to
I
that
think
person?
we will.
You
We
think you
will. Oh, yes, because I say she, because the handwriting in the Christmas card last year to him
Oh, wow. I
was
didn't know
very
about
bubbly. Yes, she sent him a
that. I
Christmas
didn't know
card.
about that. Wow.
And actually, I have one for her today. And I know she was young. I know that they were flying the bone marrow in that to get put in. I know that wherever this person was, they had taken it out of them, and the courier had gotten it that day, and within 24 hours, it was put in Jackson.
That's true.
And from what I heard about the courier, because we were always worried about, are we going to lose it? And even though they're very good, as parents, you just think of everything. And I know Dad was very worried, and I looked at him, I said, listen, it's going to get here. Nothing's wrong. Just be positive, because I feel good about this. And they gave him the transplant. I know you had said you looked at a few donors, but the one that they focused on, they were 100% match for Jackson.
And I may not have told you all the details, but just for the sake of the students, there are a lot of variables we look at when we try to choose a donor from the National Marrow Donor Program. We look at, first and foremost, that they have the right HLA. So we look at 10 loci, 10 genes of transplantability, compatibility, and we look at that first. But we look at other variables too. We look at the age of the patient. We tend to believe that younger patients have more robust stem cells, and so there may even be a cutoff in some cases if you're like 55. We look at their blood type, because if you have the wrong blood type, you have to deplete the red cells so that there isn't a transfusion reaction.
They didn't have the same.
So that graft had to be worked out by, we have a graft engineering lab here at Hopkins. We look at the viral status. We look at things like CMV. And some patients that are CMV negative and they get a CMV positive bone marrow can be susceptible to getting a serious.
They were CMV negative, I remember reading
So
that.
we look at that, and we have choices, and we run it through the National Marrow Donor Program, and we'll look at HLA compatibility, we'll look at the age of the donor, we'll look at their viral status, and even that is not really complete, because there are a lot of other, could be other viruses, many of them are screened for viruses, but there could be other unknown variables that you can't control for.
Right.
So in some aspect you're rolling the dice, but we try to make the process as comprehensive and safe as we can.
Which we know to check for the viruses now, because David, back in the 70s, the boy in the bubble, the original little boy, from what I've read, and you'll have to read up because I may be wrong, his sister eventually at 12 and a half, he was 12 and a half, I believe, she became his donor. And I think she may have carried the virus for leukemia. I'm not sure, you'll have to read
I don't know
that,
the lore, but I'll take your word for it.
but I know it
I'll look
ended,
at
one of the
PDA.
viruses that we didn't look up, but it ended up taking him out. He didn't make it. But we've come such a long way with that.
Question?
Thank you again for coming.
You're welcome.
Feel free to not share this if it's private or you don't feel comfortable. I was just wondering if you ran across any financial barriers in the process of trying to get the bone marrow transplant, and if you could just speak some about what that process looked like for you.
I don't have a problem sharing that, actually, because you, as a doctor, you should know this. Dr. Hinkle, his pediatrician, and Dr. Letterman fought to get him in here. Originally, we had insurance through we have insurance through the state. And Jackson and all of us had United Healthcare. And they wanted us to go to DC or I believe maybe DuPont. And Dr. Hinkle wanted him at Hopkins. She said, they live in Cecil County. I am not sending them to DC all the time. And Dr. Letterman was aware of what was going on. And from what I've heard at the pediatrician's office, Dr. Hinkle was screaming in the back at the insurance company to get him to get seen, because, like she said, we can't have a newborn screening and test him and not have the resources for him to be seen. He needs to be seen. This could be life or death. And I know Dr. Letterman had us approved for like 20 visits. And then when I found all of this out from our social worker, I had our insurance changed. And we actually switched to Priority Partners. And we've not had problems since. But that was pretty much the only, I mean, we've been very blessed because we have not been charged anything. And my dad was willing to put his house up for sale. Sorry. Just to make sure this boy lived.
Thank you.
What is IVIG?
A wonderful shot I had to give him at home after he came home. But IVIG was ran through his central line, and then we ended up doing the sub-Q at home after his central line was removed.
How frequently?
I did a shot every week. I never in my life thought I'd be able to do this. I don't handle blood well or anything like that. So it was a challenge. My mom, who is with us today, she would hold Jackson down and I would give him his shot at home. Immunology taught me how to do that. And the reason we decided was when Jackson had the infection around his central line, he was no longer high maintenance. The only thing he was really getting was the IVIG, and that was pretty much it. I mean, blood draw tests, which that was something he would have to learn, and he's still learning how to deal with. I mean, it's
So
a
you were his
struggle.
mom and his nurse?
Yes. I learned how to do everything that you would have to do. I mean, it was, and like I said, the nurses were very good. They made sure that you understood how to change the dressing over a central line. Because I don't know if any of you have ever done that, but you have to be so sterile. I mean, the gloves are flipped inside out. You just have to be careful with what you touch. And you don't want to give him that infection. I mean, there's always risk for an infection with a central line. So once we had gotten rid of that, I was very happy. I remember the doctors had come in the room and I said, they were talking about, I think maybe putting a central line back in, and I said, well, we really only use it for blood draw, and it took a lot. Can't I just give him his shot at home? And luckily enough, we have the numbing cream.
Mm-hmm.
And
Numbing cream?
yes, because
Good stuff.
there was a couple of times I poked him twice. But, I mean, he just...
Pediatricians love animal.
Oh, I love it. It's great. But when I did, the only time he really cried was when you were pushing the antibodies in him. A little boy once told immunology it felt like fizzing in your leg. And of course, Jackson can't tell me what he's feeling. So I don't think it really hurt him. I just think it was something different. But I'll never know.
So Jackson needed artificial antibodies.
Yes.
One of the things that happens when you have a SCID is you can't make antibodies properly. So is he still on IVIG?
No. I think from the other day, I don't know if you understand what CD4?
I understand it. I think you guys do.
CD4 count is, I don't really understand it, but from what I know, it's normal. He is normal. And it just came back the other day, and I
Can you
said,
call the number, because I don't know it off the top of my head.
I have my chart.
I think it was over 1,200 or 1,400, but I'll have to
I know
check.
it just said like 50 point something, like, she said he was at 15, and then I think it's at 50 point something. Does that sound right?
It's normal, sounds like.
Mm-hmm. Yeah, she said he's normal.
And what about vaccines? Did he get his vaccines?
So we've started vaccines, I believe, September. We started vaccines. He is not getting live vaccines yet. Every time they go to give him a vaccine, I'm like, it's not live, right? Because I don't want him to get chicken pox or anything like that. But we were just discussing a week or two ago that Dr. Younger explained the last time he got his sub-Q, you have to wait so long before he can get his vaccines. So she's looking at him sooner than what I think, because we assumed it would be school age almost.
So when you give a vaccine in patients who have SCID and in other bone marrow transplant patients, what we often do is several weeks later, we do a blood test to see if they have a titer to the vaccine. Have you had those?
A jump in it, yes.
And?
He's looking good.
Yeah, he's making antibodies.
He's looking very good from what Dr. Younger's words are, he looks fabulous. So.
Questions? What medicines is he on now?
He's just taking fluoride because we have well water, vitamin D, which doesn't really have to be a daily thing because he's almost normal with that. And the hormone pill we're doing, and I think...
How does that compare to all the medicines that he was on right around then?
So just so you know, keep this in mind for when you become doctors. Mango, I believe, you could put all the medicine. A pharmacist at Hopkins told me about it, and it works great because my phone was going off constantly telling me when to give him medicines. He was on so many that I was terrified. I think he was on probably 6 to 9 when we first left the hospital.
Yeah.
And CellCept was very important, I knew.
Yeah.
There was a...
Tacrolimus? Were you on tacrolimus?
Yes, that was the other one I was trying to think
Yeah,
about.
that one is very tricky because you got to get constant levels to make sure
Yes.
it's in the right range.
And you can't give it, you have to always remember not to give it in the morning when you're coming in for blood draw. Jack.
He's a friendly guy.
Oh, yeah.
Yeah, so you've gone from, I don't know, probably 15 to 20 medicines to now basically a couple, vitamin D and fluoride and probably things that might give the child a bad.
Right, nothing that's life or death, that's how I feel. Because when he had C. diff, it was very stressful with the medicine. We ended up giving him vancomycin because the original one they had prescribed, he would not take it. It was awful.
So we're almost out of time. I have one last question, but what do you guys, any final questions, comments?
Thank you for the app suggestion.
Oh, you're welcome.
That'll be really helpful for a lot of patients, I think.
It will, trust me, because it's a great reminder, and especially when you have multiple medications at multiple times, and you can check them off. So you make sure that you've given it because you will not remember what you have done.
I guess I'll end it and I'll ask you, so what are your concerns for the future?
So I always still have the concern of how, I guess his kidney and liver they'll be okay from all the medications and the bone marrow transplant, but that's always still in the back of my head. I'm worried about when he decides to have children. I believe that the boy can be, or I'm not sure if one of them can be a carrier. I thought one of them could.
It's on his X chromosome.
Right. So, but I mean, it's him having kids worries me. I'm really not concerned about him being a normal child anymore. I mean, we were so lucky this was diagnosed early because we could have had several complications. I don't want to say it was easy, but we're really blessed because it could have been a lot worse. So, yes.
Thank you so much for coming. Can I ask a question? I believe he has an older sibling, a sister, is that correct?
Yes.
How many years difference?
She's 3 and he's 1.
Okay. So maybe you could just tell us very briefly, how did things go? She didn't have SCID, right? And I'm just curious as to what was her response, reaction when she found out that he was ill and when he came home with all these medicines and all this attention. I mean, was it difficult for her?
Well, thankfully, she watches Doc McStuffins, so that helped a little bit. Every day that I flushed his line when we got home, she was in the room with me. She was never sick around him. She didn't go to daycare. And Haley would sit there with me, and she would just try to talk to him, and I would flush his Haley or Nurse Haley because she just really thinks that she helped. She was very good about his central line and his NG tube. She didn't touch anything. I think she realized it was very serious because they were very young in age when everything was going on. It was hard for her, though, being away from him and being away from the family, because I basically was away from her for 3 months and hardly had seen her. Plus, I didn't want anybody around him just to protect him. But other than that, she handled everything very well, and we still talk about it, and she watches out for him. She's definitely the big sister.
Fabulous. Thank you again so much. I want to thank Erin, Jackson, and Grandma. They're out there somewhere. I don't know what they're doing.
He's running around.
He's running around, causing trouble. We want to thank you for sharing your very special story. We really, really appreciate it.
Thank you.
That's all we have time for. I guess if there are any questions, I don't know if you're going to stick around. But
Oh yeah, I'm not in a rush. We don't get out much.